discuss about expert perspective in inclisiran. It's a very exciting new molecule. Indians have a high CV risk. We all know about it. Since we have known that Indians have a very high risk of ASCVD for many years. We have understood this, but we never understood how to treat them. Is there any specific criteria for Indians or not? We get earlier CV events. Our patients are 10 to 15 years younger compared to the Western population. Our mortality rates are very high. And whenever we do angio, we see multi-vessel disease more commonly as compared to single vessel disease with the foreigners do see. So elevated LDL-C levels are crucial due to their strong and linear association with ASCVD, as you can see from this. Several trials have shown that as the LDL level increases, the mortality and the chances of MACE also increases. And we all know that 1 millimole per liter reduction, that is 39 milligram per deciliter decrease in LDL, is associated with 21% reduction in the major cardiovascular events. And you can see this is a combination of both secondary prevention trials and primary prevention trials. As the achieve that lower and lower LDL, the outcome seems to be much better. This is a 5-year secondary prevention trials based on the event rates. You can see this. The lower the achieved LDL, better is the outcome. So trend line for atherosclerotic cardiovascular disease in primary and secondary prevention. This is combination of both primary and secondary. As you can see, these red dots are of secondary and gray dots are of primary. So trend lines for ASCVD in primary and secondary prevention are virtually superimposable and strongly and linearly associated with the absolute HDL-C level which we have achieved. So what lower the LDL you have achieved, better will be the outcome. What are the latest guideline recommendations to strike early, strike strong for intensive LDL-C lowering to achieve targets in high-risk patients? Now, lower is better and the lowest is the better in my opinion. And this is several guidelines are there. First is this 2023 ESC guidelines or CSI 2023 guidelines. LDL reduction should be less than 55 milligram per deciliter. This is as per the USC guideline, which Cardiological Society of India has also accepted. But our lipid association is much more aggressive. They feel it should be less than 50. In patient with second CV events within 2 years, an LDL-C goal of less than 40 should be achieved. So patient who has, say, stroke, and within 2 years he gets another episode of atherosclerotic cardiovascular disease, which does not necessarily mean the neurological or stroke. Suppose he gets a myocardial infarction within 1 year of getting a stroke, then we should achieve a target of less than 40 milligram per deciliter. What about this 2022 American College of Cardiology expert consensus decision pathway? It shows LDL-C should be brought to less than 55 milligram per deciliter, plus LDL should be reduced by more than 50% compared to the baseline value. So if your baseline value is 100, so you should achieve more than 50. So there the target will be 50. So two criteria has to be met. It is not or, it is and. LDL-C reduction should be less than 55 milligram per deciliter and LDL reduction should be less than 50% of the baseline value. Now our Lipid Association of India guideline or our Lipid Association of India consensus statements are very aggressive. It says very high CV risk, LDL should be brought to less than 50 milligram per deciliter. Unlike American, unlike European, they want it to be less than 50 milligram per deciliter. Then they have devised a category: extreme CV risk category A, extreme CV risk category B, and extreme CV risk category C. What is meant by extreme CV risk category A? There you have to bring LDL-C to less than 50 milligram per deciliter, and LDL reduction should be brought to less than 30 milligram per deciliter. That is optional, but this is firm. If you're an extreme risk category, like person who has suffered a myocardial infarction or has undergone angioplasty or bypass or has a stroke or peripheral vascular disease, then you should bring it to less than 50 milligram per deciliter, which is strongly recommended. But if you can achieve less than 30 milligram per deciliter without causing undue side effect, then it is a very good. It is an optional target. Whatever extreme CV risk category give, where you should bring it to less than 30 milligram. It is a compulsory. Patient who has suffered a second episode within 2 years, then you should bring it to less than 30 milligram per deciliter. And what is extreme CV risk category C? LDL-C reduction to less than 10 to 15 milligram per deciliter. It is possible with newer therapies. So we should bring this extreme CV risk category C patient to achieve an LDL-C level of less than 10 to 15 milligram per deciliter. No significant association between very low levels of LDL-C and safety outcomes. We all know that there is always a concern that if you bring down LDL-C to a very low level, will it cause hemorrhagic stroke or not? Will it cause a cataract or not? Will it cause any other cognitive changes or not? It has been shown that it does not cause any harm. So lowest is the better. In my opinion, lowest is the better. So safety event achieved by LDL-C levels over a median of 2.2 years. And this is the data from probably Fournier study. which have analyzed more than 25,000 patients. And it has, yes, it is full-year study, 25,900, almost 26,000 patients. It has been shown that serious adverse events are much less at whatever level you have achieved, So these are different levels which you can see this. When the level is less than 0.5 millimole per liter, that is 19.3 milligram per deciliter, look at this. There's hardly any serious side effects. Lowest is better at every level, whether it is 20 to 40, 40 to 60, 60 to 80, 80 to 100, or whatever it is. Adverse events leading to discontinuation. Again, even if you achieve less than 20, that is 19, nothing happens. Liver enzyme does not elevate. CPKMB is not elevated. Neurocognitive disorder, which we are a little worried about it, is not statistically significantly affected. New onset of diabetes, same. Whatever level you achieve, cataract related side effects are same. Non-CV deaths, all are same, So there is no reason to believe that the lower is harmful. So try to bring it to as low as possible. Extremely low LDL level does not affect capabilities to produce steroid hormones or bile acid productions. They are preserved. So no side effects, but all the effects are preserved. You get a statistically significant benefit in the terms of mortality and in terms of reduction in MACE. You do not get any increased incidence of neurocognitive disorders or increased incidence of new onset diabetes or new serious adverse events which can lead to discontinuation of therapy. So lower is better. Lower is better. Lowest is the best. So let us discuss about what is inclisiran. It is a first-in-class small interfering RNA therapy to lower the LDL-C levels. It is a very interesting structure. You can see this. There's a two strands. One is called passenger strand. One is called guide strand. Passenger strand is a sense strand, and the guide strand is an anti-sense strand. And there is a GalNAc conjugate. This GalNAc conjugate allows it to bind with the hepatocyte. So there is a works only in the liver, and there will be no off-target extra hepatic side effects like muscle pain, which is very common with statin. So inclisiran specifically works in the liver. It mimics the body's process of RNA interference, which is restricted to the cytoplasm of the liver cells only. Conjugated with GalNAc for specific uptake by hepatocyte, as I was trying to tell you, this allows it to be bind with only hepatocyte and nowhere else. So there is very low likelihood of off-target binding to the muscles or other organs. Inclisiran plasma levels decline within 24 hours and are undetectable within 48 hours. But it works. So it prevents production of the target protein whenever you use this sort of small interfering RNA. There is a hepatic significantly high uptake in the liver, and therefore circulating LDL-C production from the liver is reduced, and in the process we will get reduction in LDL-C levels in the bloodstream. What is the current Indian scenario about this, whether we have received approval or not? Inclisiran is indicated in adults with primary hypercholesterolemia, whether it is heterozygous or non-familial hypercholesterolemia or mixed dyslipidemia, or maybe in the homozygous hypercholesterolemia also, in addition to the diet therapy. It is also used in combination with statin or statin with other lipid-lowering therapies like ezetimibe or bempedoic acid in patients unable to reach LDL-C dose with maximally tolerated dose of statin. So whenever you are using statin, the goal is not been achieved. Patient is tolerating statin, you have given that whatever tolerated dose a patient can tolerate, but still he has not achieved, then you can use inclisiran. Sometimes we prefer to use other oral agents. So we give statins, target is not achieved, we can give ezetimibe, target is not achieved. We can add bempedoic acid, even then target is not achieved. On top of these three orally acting drugs, we can use inclisiran. It can be used alone or in combination with other lipid-lowering therapies in patients who are statin intolerant or for whom statin is contraindicated. Now, there are good number of patients which cannot tolerate statin, like they get a lot of muscle pain, myopathies, myositis, and their quality of life gets disturbed. So there you can use alone inclisiran, or maybe you can use non-statin therapies like bempedoic acid or inclisiran, and still if target is not achieved, you can combine it with inclisiran, or maybe you can give straight alone also. Inclisiran suitable patient profiles are like this. Inclisiran is useful in high cardiovascular risk individuals with atherosclerotic cardiovascular disease whose high LDL-C levels remain inadequately controlled with standard lipid-lowering therapy. So you have given statin, you have given bempedoic acid, you have given ezetimibe in whatever dose patient can tolerate, and still your target is not achieved. And in a good number of patients, this target will not be achieved, particularly in extremely high-risk patients, where our target is to bring it down to less than 30 or maybe even 10 to 15 LDL-C. So there you will have to use it on top of all these three therapies. It is also useful in the treatment of heterozygous familial hypercholesterolemia. We know that heterozygous familial hypercholesterolemia is a killer condition. Most of these patients will eventually develop significant atherosclerotic cardiovascular disease. This can be used in them also. It's a 1.5 millimole injection, very less painful. It contains 284 milligram of inclisiran, and it has to be given as a single subcutaneous injection, the way we give low molecular weight heparin, or maybe the way we give it insulin. It's very simple. The first dose, day 0, then at the end of 3 months, that is after 90 days, and then every 6 months till life. This contains 300 milligram of inclisiran solution, of which 84 milligram is inclisiran. It uses water as a diluent. Sodium hydroxide and phosphoric acid is there to maintain pH at 7, and it can be stored at room temperature. It does not require any excessive freezing or anything. As I told you, day 1, day 90, and then every 6 months, continuous for life. How it is to be administered? Subcutaneously, around umbilicus, injection in the abdomen by healthcare professional. So it's very simple. It's almost painless. Under clinical investigation in the Orient Development Program to determine efficacy, safety, and tolerability. This is going on, and now we have a data that it not only reduces LDL cholesterol, but it improves outcomes. So it reduces MACE, it may reduce mortality also. Dose and admission. There are few commonly asked questions. Suppose if somebody misses a dose, what to do? If a planned dose is missed by less than 3 months, inclisiran should be administered and dosing continued according to patient's original schedule. So if you have missed it, within 3 months you can give inclisiran and then continue like original schedules of every 6 months. If a planned dose is missed by more than 3 months, a new dosing schedule should be started. Suppose you remember after 4 months, then you give another injection of inclisiran, and from that injection, start calculating at every 6 months. So if a planned dose is missed by more than 3 months, a new dosing schedule should be started. Inclisiran should be administered initially, again at 3 months. So start from beginning, first dose, then at 3 months, and then every 6 months. Treatment transition from monoclonal antibody to PCSK9 inhibitors. Now, PCSK9 inhibitor has become very popular. It is available. It has to be given every 2 weeks. It is available in India. Many times we give it. So how do we transition? Suppose a patient is taking twice monthly injection of PCSK9 inhibitors. Now you want to switch it over to every 6 month injection. How we do it? Inclisiran can be administered immediately after the last dose of monoclonal antibody PCSK9 inhibitor, that is evolocumab, which is easily available in India also. And to maintain LDL-C lowering, it is recommended that inclisiran is administered within 2 weeks after the last dose of monoclonal antibody. So when you give an injection of monoclonal antibody PCSK9 inhibitor evolocumab, the second dose is due after 2 weeks. So you start within 2 weeks so that LDL-C does not rise. This is a CSI guideline which clearly mentions about inclisiran. This is given last 2023. It talks about the management of dyslipidemia in acute coronary syndrome patients. Non-fasting lipid profile should be done. There is no need to do fasting. For lipid, LDL-C cholesterol, no need of fasting. So you do a lipid profile which is a non-fasting state. Then start with rosuvastatin 40 milligram plus ezetimibe, or 80 milligram of atorvastatin and ezetimibe. If lipids are elevated, look at the LDL-C. If you achieve this target of less than 55, which is the CSI guideline, which is the European Society of Cardiology guideline, then you continue with the therapy. Okay. Then check lipid at the 4 weeks. And if it is less than 55, you continue with the same therapy. If the lipid is not at target, that is more than 55, then third drug you add bempedoic acid. First you start with 2 drugs, atorvastatin or rosuvastatin plus ezetimibe. Now on top of that you add bempedoic acid. Check lipids at 8 weeks. If still target is not achieved, if target is achieved, fine. If it is still not achieved, then you have 2 choices. Either you can use PCSK9 inhibitor, which is every 2 weeks injections, or you can use inclisiran, which is every 6 month injection. Then look at your target after 12 weeks. Most of the time you will achieve the target. So this is how lipid management should be done in the setting of acute coronary syndrome. This has to be done like this. If you have a recurrent ACS, then target is less than 55, or as per this guideline, it should be brought to less than 40. So Cardiological Society of India, that CSI guideline, recommend that in patient with acute coronary syndrome, if an LDL-C target of 55 per milligram per deciliter is not achieved with high intensity statin, ezetimibe, bempedoic acid combination, then another non-statin drug like PCSK9 inhibitor or inclisiran can be administered. So CSI guideline definitely mentions about inclisiran. So whenever you prescribe inclisiran to somebody, it is not out of guideline. It is a recommended guideline. It is a nice guideline for atherosclerotic cardiovascular disease and heterozygous familial hypercholesterolemia. We all know about this thing. There also it speaks about it, and the guideline almost is similar. You use statins, then you use ezetimibe. If it is not well controlled, you add bempedoic acid, and after bempedoic acids, ezetimibe and statin. If guideline directed dose target is not achieved, that is less than 55, then maybe you can consider injectable therapies, in which inclisiran is very popular. I believe in NHS, in UK, it is approved, and a lot of Britishers are still taking inclisiran in preference to this PCSK9 inhibitor. Again, the same thing, ACC expert consensus, American College of Cardiology, they also are almost in the same line. So you start with statin, whatever dose the patient can tolerate, then add another non-statin oral therapies, and still if the target is not achieved, maybe you can consider injectable therapies, and we have a two choice. One is PCSK9 inhibitor, evolocumab, which has to be given every 2 weeks. This is again a subcutaneous injection. Or you can use inclisiran, which has to be given day 1, day 90, and then every 6 months. There are a lot of trials with inclisiran which have shown that the inclisiran is very, very useful as far as LDL-C is reduction. And there are trials coming to show that not only it reduces LDL, but it also reduces MACE and mortality. So these are placebo-controlled double-blind randomized trials. These trials are labeled as Orion trials. So we have Orion series. Orion 9 trial included heterozygous familial hypercholesterolemia patients. There was 482 patients included in this. The study was conducted in United States, Canada, Europe, and South Africa. Treatment period was of 18 months. The dose was 300 milligram or 284 milligram of inclisiran and placebo. So it was a placebo-compared injectable trial, and status is complete. Now data will come. Orion 10 included atherosclerotic cardiovascular disease patients. That included 1,500 patients done only in single country, that is United States. Same dose was used. They were studied over a period of 18 months. And Orion 11 was atherosclerotic cardiovascular disease patients plus ASCVD risk equivalent. So those who had established atherosclerotic cardiovascular disease plus those who have multiple risk factors like obesity, hypertension, smoking, they were all included. And this study was conducted out of USA, that is in Europe and South America. Same dose was used. Again, same time, 18 months, and the data will come soon. So whatever information we have is that inclisiran demonstrates an effective and sustained LDL-C reduction with low inter-individual variability. So like in statins, in some patient will respond very well, some patient does not respond so well. Here there is a low inter-individual variable. So person to person variability is much less. And we have done a pooled analysis of these 3 trials which I showed you in Orion 9, Orion 10, and Orion 11. Based on the pooled data, because there were small studies of 482 patients, 1,500 patients, 1,600 patients. So when you combine, you will get some statistically significant data. And it shows that LDL-C percentage change from the baseline was quite significant. At day 510, there was a change of 50.7%. So from baseline, 50% LDL-C reduction was achieved. Change from baseline at the day 510, so quite significant. There was a time average change between day 90 to 540, that is about 45%. So significant reduction. Whenever you give this inclisiran injection over a period of time, LDL declines significantly, and it persists. The decline persists. So 50.5% sustained LDL-C reduction. The word is sustained LDL-C reduction between the group. It comes, and from the 90 days to 540 days, you start seeing the effect. 50.7% effective LDL-C reduction between the group at the day 510. If you take between 90 to 510 days, you have 50.5% reduction. And if you check only at the end of 510 days, you have 50.7% reduction. So whatever may be the starting dose, whatever may be the starting level of LDL, you will have at least 50 to 51% reduction in the LDL at the end of 510 days. Excuse me. So with inclisiran as a strong complement to maximally tolerated doses. So this is a study where all these patients were already on whatever dose they were tolerating of the statin. So on top of statin, if their target is not achieved, you give inclisiran and you will have such a significant reduction in the LDL-C cholesterol. around 68% of patients achieved an LDL-C level of less than 70 milligram per deciliter, and 52% of patients achieved an LDL-C of less than 50 milligram per deciliter. Remember, our Lipid Association of India (LAI) guidelines suggest that all our Indian patients who have suffered myocardial infarction or had any evidence of atherosclerotic cardiovascular disease, we should achieve a target of less than 50, and that can be achieved not only with statin, but when you combine it with statin, almost half of our patients, that is 52% of patients, will achieve an LDL-C target of less than 50 milligram per deciliter. Inclisiran was studied in Asian patients in Orion 18 trials. The patient who had atherosclerotic cardiovascular disease or high risk for atherosclerotic cardiovascular disease, they were analyzed, and median percentage change in lipoprotein A from the baseline over time with inclisiran and placebo group. So this was very interesting data, because lipoprotein A, as we all know, is a risk factor for atherosclerotic cardiovascular disease. We all know about it. This is a lot of Indians do have a high lipoprotein A, but up till now there were hardly any therapy to reduce lipoprotein A. But now we have another therapy in the form of inclisiran. Not only it reduces LDL-C cholesterol, but it also reduces lipoprotein A, which is a risk factor. Up till now we didn't know how to treat it, but now we have a therapy for it, lipoprotein. Of course, as of now it is not approved for lipoprotein A reduction, but you will have, this is an additional benefit. Look at this, from 40 to almost 46% reduction in the LPA level. So geometric mean lipoprotein A ratio to baseline from day 60 to day 360. Look at this. Lipoprotein level comes down from baseline at the end of 360 days, and starts coming down from day 60, day 90, day 150. At every level, you see lipoprotein level is decreased, and it remains decreased. So placebo-adjusted mean percentage reduction in LDL-C from baseline with inclisiran was 57.2%. So 57.2% reduction in LDL-C in Asian patients, and ratio of LPA to baseline levels was approximately 41% lower. You can see this significant reduction compared to placebo at day 300. So within 1 year, you will have significant reduction in LDL-C to the tune of 57% in Indian patients, in the Asian patients, and you will have significant reduction in the LPA to the tune of almost 41 to 46%. Orion train trial. There are a lot of Orion trials. So Orion train trial was looking at the atherogenic lipids and whether it increases HDL-C. We all know that HDL-C is a protective cholesterol. So does increase help in improving LDL-C and help in decreasing atherogenic lipids or not? That is what we wanted to see. And Orion 10 trial studied the role of inclisiran in these situations. And what we wanted to see was changes in lipid parameters at 510 days, day 510. So total cholesterol was decreased by 33.6% compared to placebo. ApoB, which is atherogenic molecule, which we know is reduced by 45%. Non-HDL cholesterol, again a marker of atherosclerosis, was reduced by 47%. Triglyceride was reduced by 15%. Lipoprotein A was reduced by 22% in Orion 10 trial, and HDL-C was increased by 7.5% compared to placebo. And if you adjust it with placebo, you will have significant reduction. And these p-values, as far as total cholesterol, ApoB, and non-HDL cholesterol is concerned, is significant, less than 0.001. So not only it reduces LDL cholesterol, it also reduces ApoB, non-HDL cholesterol, triglyceride, and lipoprotein A. At the same time, it improves protective cholesterol, HDL. Inclisiran was generally very well tolerated. So now I have spoken about the safety, but safety has to match with the, up till now I spoke about the efficacy, I'm so sorry. But efficacy has to match with the safety. There are many drugs which are very efficacious, but the safety parameters are not acceptable. But this is a very good drug where safety and efficacy matches. So what is the safety of inclisiran? It was as good as placebo. Excepting for a small injection site reaction, there is no other major problems. So treatment emergent side effects, more than one, hardly any compared to placebo. Serious treatment emergent side effects, hardly. Treatment emergent side effect leading to discontinuation, hardly any. Then there is no incidence of increased diabetes, nasopharyngitis, upper respiratory tract infection, hypertension, arthralgia, or myalgia. Hardly ever it causes. So the side effect profile is as good as placebo. Treatment emergent adverse effects and serious adverse effects generally similar between inclisiran and placebo group, except for ISRs, that is injection site reaction. Patient do come down of little pain during the injection, but it's a self-limiting, doesn't require any therapy. More participant experience injection site related side effects in the inclisiran group. Predominantly, it is mild and transient. None were severe or persistent. Does not require discontinuation, and they are self-limiting and settle down on its own. You can know this long-term safety data. It is very well tolerated. Dual safety up to 6.8 years of exposure. We have data up to 6.8 years, documented data. It has not shown any major side effects. Orion 8, which is an open label extension trial of Orion 3, 9, 10, 11, of 3,274 participants, assessed long-term efficacy and safety of twice yearly inclisiran in patients with high cardiovascular risk and elevated LDL-C levels. It showed that inclisiran could reduce LDL-C levels in long term while being very well tolerated without any major side effects. Inclisiran acts in the cytoplasm of hepatocytes. It does not in the nucleus. It works at the cytoplasm, not at the nucleus level, so that there is no risk of carcinogenicity and immunogenicity. It does not cause any changes in the chromosome. It works in the cytoplasm, so there is no risk of carcinogenicity and immunogenicity. What about the results from Orion 8, which is the largest trial of safety and efficacy? 82.7% of these patients enrolled had atherosclerotic cardiovascular. So these are high-risk patients. The mean baseline LDL-C level was 113, despite being on initial therapy with statins and all those things. 78.4% of these patients achieved their pre-specified LDL-C target at the end of the study. Approximately 90% of patients achieved their global lipid target at any visit. So every visit you check it, and at every visit the target was achieved in more than 90% of the patients. On an average, LDL-C levels were reduced by approximately 50%. I showed you that slide at the end of the study. And overall median exposure was 2.6 years in these Orion 8 trials. And total increase in exposure was more than 8,000 patient years. So we have a long and large data, both for efficacy as well as for the safety. The safety profile of inclisiran in Orion 8 trial was consistent with the previous studies. Reaction at the injection site was the only side effect which was more common. It occurred in about 5.9% of patients compared with 8.2% in the inclisiran arm. So in inclisiran injection site was slightly more as compared to placebo injection sites. Now I have shown you that it reduces LDL-C cholesterol. I have shown you that it reduces LPA. I've shown you that it reduces triglyceride, it reduces ApoB, it reduces non-HDL. But does it translate into any cardiovascular outcome data? Does it reduce myocardial infarction? Does it reduce stroke? Does it give you mortality benefit? So we need outcome data. And now we have some outcome data with inclisiran. And that is this. Orion 4 and Victorian 2P are ongoing cardiovascular outcome trials with complete dates anticipated in 2026 and 2020. Victorian is, to the best of my knowledge, is for primary prevention, and this Orion 4 is for secondary. While the results of CVOTs are ongoing, a recently published pooled patient level analysis of Orion 9, 10, and 11, which I showed you, 9, 10, and 11, provided some insight into the possible cardiovascular benefits of treatment with inclisiran. There was a significant 26%, I repeat, there was significant 26% reduction in the composite outcome of MACE, that is major adverse cardiovascular events, compared to placebo at the end of 18 months. Mendelian randomization studies with 20 million person years of follow-up, proven dose-dependent log linear association between the absolute magnitude of exposure to the vasculature of LDL-C and the risk of ASCVD was calculated, and they have found that there is no major adverse outcomes. Thank you so much.